Thanks, Rachel. I immediately forgot. We're recording it, so if anyone else, I guess, wants to watch later, they can do. So yeah, the purpose of this session really is just to go over some ASTUTE related things. It's a bit of a refresher sort of SIV, so a lot of the information will be quite similar to what was on the SIV, but just kind of a reminder of some key points, and also just an opportunity for me to ask some questions about how things are going at your site and get any feedback, and yeah, sort of a bit of a Q&A as well. So obviously if you have any questions, let me know. Either just shout or put your hand up, and I'll try and come to you. And otherwise, yeah, I'll do a bit of a few questions along the way. So this is the content of the SIV today, so I'll run through. Hopefully I won't take up too much of your time. So just a bit of brief background, as you will already know, and as I will have gone through before, generally in real life clinical practice, patients must fulfill the NICE criteria to be able to be prescribed adalimumab. So that's listed below. The inadequate response to steroids, active inflammation in both eyes, vision getting worse with high risk of blindness, and also a poor response to other immunosuppression. And so adalimumab is not prescribed in quite a lot of cases. So if the disease is inactive, if you're treating cystoid macular edema, and also if your patient needs it as a first-line immunomodulatory treatment. So ASTUTE wants to kind of expand who we would give adalimumab to, so outside of those who must fulfill the normal NICE criteria. And then we also want to kind of look at the points below, so to establish whether it's more effective than other immunosuppression, to establish if there's any pragmatic starting and stopping criteria, to determine whether adalimumab can be broadened to include cystoid macular edema, and also to look at any clinical biomarkers for treatment response. So just the trial pathway, as hopefully now most of you will have patients in all aspects of the pathway, but obviously it is slightly convoluted. So we start with the treatment run-in, which is when everyone is on the adalimumab open label drug for 16 weeks. And this starts with the induction dose of 80 milligrams and then is not tapered down, and then it's followed by 40 milligram fortnightly injections. And then it's during this 16 weeks that the prednisolone is tapered to 5 milligrams or less per day. You have treatment responses assessed at the end of 16 weeks, and if the patients are non-responder, they exit the trial, and if they're a responder and they want to continue, then they get randomized to the adalimumab or placebo. And this is the point that they enter the randomized trial, which is sort of the main part of the trial, which has the 12 weekly follow-up visits for the first 48 weeks and then 16 weekly after that. And the patients are either on adalimumab or placebo, and this is fully masked. The treatment failure is assessed at every scheduled visit, and also can be assessed at unscheduled visits if you believe that treatment failure has occurred sort of outside of these windows. And if there's no treatment failure, then the participant just stays in the RCT and continues in the study. But if they have treatment failure, then they will go back and repeat the treatment run-in. So this will basically be doing the whole study again, effectively. Then move back into the repeat treatment run-in, have the 16 weeks of open label adalimumab, and then at the end of that 16 weeks have their response assessed again. The only thing that's slightly different about the repeat treatment run-in is they don't have the induction dose, so they'll just move straight on to the fortnightly 40 milligrams of adalimumab. If they're a non-responder at the end of the repeat treatment run-in, they'll just exit the trial. They can continue with follow-up without the IMP if they want to, but generally speaking, patients would just exit the trial at this point. And then if they are a responder, then they go back into the randomized part of the trial, having their treatment arm switched and the follow-up visit, well, RCT follow-ups restarted. So they'll go back to having their follow-up visits every 12 weeks, like they did in the first RCT. Then after 48 weeks, it would go to 16 weekly visits. And the repeat treatment run-in can happen twice. So if they fail later, they can do the whole thing again. So the patient could end up being in the whole pathway 3 times. We have a target of 174 randomized patients. So this is 174 in the main trial. And currently we think that this will be approximately 300 patients into the TRI to achieve this, or perhaps slightly lower. This number is slightly variable based on the response rate. So when the study was set up, it was estimated with a 50% response rate. So we thought we need 400 patients, but now the response rates are sitting at about 67% quite consistently. So if it stays around there, we'll probably need, I don't know, 300, slightly less, maybe 280. So that kind of first number is slightly variable as the study goes on. Just to highlight the primary and secondary outcomes. So the primary outcome is the time to first treatment failure, and that is as I mentioned in here, so that's in the randomized trial, what they get assessed at every visit. So that treatment failure, the time to treatment failure is the primary outcome. And then we're looking at a range of other secondary outcomes, so individual treatment failure components, which I'll go through in a minute, and other adverse events, health-related quality of life, side effects, visual function, and other sort of patient-reported outcomes. So just summary of all the features as we've gone through, and as you're probably aware of, it's a placebo-controlled masked randomized trial with a treatment run-in with 16 weeks of open label adalimumab, and then only responders will enter the main trial. Those in the main trial are randomized 1-to-1 to adalimumab or placebo. Oh, I didn't update this number, but yeah, 300 participants approximately into the TRI and 174 required in the RCT. The total study duration here is 48 months, but this again is going to be extended, assuming approval of the extension request that I'll touch on in a minute. So this is just our overview of why patients should participate in ASTUTE. So we kind of have the benefits for those patients and also for future uveitis patients. Generally, we give access to a wider group of patients than would normally be able to have adalimumab. So this allows us to see whether those who wouldn't normally have access to the treatment respond well to it, as well as those who would ordinarily. And also everyone in the trial will be treated with adalimumab. So because we have the treatment run-in aspect, everyone who starts a trial will know they'd be given the drug and will have the opportunity to see if they respond to it and to see if it works well for them. And even when in the RCT, if they are randomized to placebo and have treatment failure, they can swap arms. So we'll also be given the opportunity to sort of end up on the adalimumab. And again, the trial has been designed so that the follow-up visits approximately match what they would have in usual care. So hopefully those visits can sort of be combined and there'd be not any extra kind of hospital visits for the patients. And then we also have the benefits for future patients. So this will, because we'll investigate the characteristics of patients who do and don't benefit from it, this will inform clinicians and doctors in future to have a better idea about who should be prescribed adalimumab. We're also looking at what the minimum dose of steroids that's effective to treat patients. Obviously, we want to keep steroid usage low, but without having any sort of negative effects. So we're looking at the minimum dose that is effective. And then we're also looking at a range of sort of other patient-related side effects. So things like on their quality of life or on their work, and other sort of hospital resource use. So onto the main, the beginning of the trial, the patient screening and enrolment. We have a two-stage screening process. So there's pre-screening, which is before consent, and this is a screening log that we have provided with you. It's all potential participants, and there'll be no identifiers recorded because it's all pre-consent. And we ask that you pre-screen every patient with autoimmune non-infectious uveitis who meet the 3 inclusion criteria, which I'll show on the next page, but that's kind of being over 18, being on more than 5 milligrams of prednisolone, and something else I can't remember. But yeah, so he's asking you pre-screen everyone that kind of meets those criteria, as this is fair, as it allows all patients to be given consideration for the trial. It also helps us to sort of review the eligibility criteria to ensure that we're not excluding patients, and also it's transparent and what allows for transparency, so we can see how many patients were screened and also reasons for why they may not have been included in the trial. Once you complete the pre-screening and patients look like they're eligible from this point, then you can approach them and consent them. So that'll be providing the information leaflet and discussing the trial with them. If they're happy to take part and they're consented, then you'll have the post-consent full screen. And this is all the kind of screening tests to be carried out. So the screening blood tests and also some of the imaging. And then it's from this that you can decide whether or not they're eligible to take part in the trial. If they're ineligible, obviously don't enroll them, and if they're eligible, then do. And just a reminder, when you do these sort of screening tests, please make sure that all the tests have been returned and reviewed before enrolment. This is particularly more with things like MRI that might take a bit longer. If you have a patient consented and you've requested the MRI, then please make sure you get the results back and that they are fully eligible before enrolling. And we do say that they should be enrolled within 6 weeks of their screening visit, but if for any reason you feel like that isn't possible because of any sort of delays in waiting for tests, then just do let us know. Don't just enroll them anyway without making sure they are fully eligible. There you go. So this is the pre-screening CRF. That the other inclusion criteria was being able to provide informed consent, which is obviously an important one. So if they meet those 3 inclusion criteria, then we ask that you sort of go on to see if they meet any of the other exclusion criteria. Assuming that they don't, you can then confirm their eligibility, and then you can kind of provide them further information, invite them in for consent and for screening. The conditions highlighted in red here are all ones that will be tested for post-consent. So at this point, we're just kind of asking you, based on your knowledge of the patient, on their medical history, if you believe that they have been diagnosed with any of these conditions, but we will reconfirm them after consent. So if you're not 100% sure, then they will be tested for. And then this part along the bottom in green, importantly, has to be signed off by an appropriately delegated clinician. So they'd have task number 15. Yeah. So yeah, at this point, I just wanted to kind of ask around the sites. I think we have quite a few people from different sites here. If you could share any information on sort of your pre-screening pathway, if you find it difficult to identify patients, or if you have good methods for identifying and approaching patients, it would be useful for me to have some kind of feedback and maybe for others to hear how everyone's getting on. I don't know if anyone's willing to share some information, or I could probably just go around and point some people out. But if anyone has any sort of, I don't know, top tips for what works well for them, or any insight into your screening, that would be helpful. Screen.
Well, I haven't got any top tips, but I have a bit of feedback.
Yeah.
Do you know when it says that a patient prescribed or being started on greater than 5 milligrams per day of oral prednisolone, and then you look at the protocol and it says if it is reduced. So we had a patient that was on 12. So you initially say, oh, well, they're definitely ineligible, but you're going to reduce it. And it was the wording, because I read it several times over, and then it sort of, are they, aren't they?
So I think, sorry, carry on.
No, just with the protocol, it's sort of a bit ambiguous, not ambiguous, but just confusing to what was acceptable.
So yeah, for entry into the study to begin with, at this, like the very first point, they need to be on more than 5 milligrams a day of oral prednisolone. But once they're in the study and in the treatment run-in, that's the prednisolone has to be tapered so that by the end of the 16 weeks they're on less than 5 milligrams. And so it's slightly, I think the protocol is slightly confusingly worded, because there's sort of 3 different eligibilities in ASTUTE. Like there's the eligibility to get into the trial, and then once they're in the trial, to be classed as a responder, there's sort of a different criteria.
Yes.
And then again, when they're in the RCT, there's a further criteria of treatment failure. So at the point of entry into the study, they need to be on more than 5 milligrams a day of prednisolone, and that can either be they're already on it, or at the visit, like at their most recent sort of clinical visit, they're being started on more than 5 milligrams.
Mm-hmm.
That's fine. But as long as they're on more than 5 milligrams, they can enter the trial. And then it's just during that 16 weeks that this should be reduced to 5 milligrams or less by the end of the 16 weeks. And so they have to have done that to be able to be randomized or be classed as a responder at the end of the treatment run-in. I don't know if that helps in any way, but
yeah, it does. Yeah, but it's similar with the systematic disease associated. So if it's associated or not, what's the rationale there? I mean,
so
they're going to require it. They're definitely going to require the drug. It just, again, it's if it's existing and then it's okay. That was a bit ambiguous as well about the
point here.
Systemic disease, the one underneath that, both of them are kind of confused us initially.
Yeah, so that one is more. So I think the reason behind this is that if they have a systemic disease that means they need to be on more than 5 milligrams, that they would be excluded from the trial because you would never be able to reduce it to less than 5 milligrams. So like the aim of the treatment run-in is to reduce this to lower than 5 milligrams of prednisolone, with the idea that you can reduce it but still control their uveitis. So if they have a systemic disease that requires them to be on more than 5 milligrams and that can sort of never be reduced, then they can't take part in the trial because they're never going to be able to have less than 5 milligrams of prednisolone.
Okay, that clarifies it.
Does that make sense?
Yeah.
Cool. Perfect. That's good. I'm glad that made sense. Yeah, I don't know if anyone else had anything they wanted to share, Johnny.
I had wanted to share a sort of barrier. It's kind of two ones that we found that the speed at which people get hold of the adalimumab injections through the trial is slower than what we normally expect from the NHS pathway. Okay. So that's sort of a deterrent to recruit patients. And the other more sort of fundamental problem is that we only really consider adalimumab in people with sight-threatening disease, and therefore those patients we wouldn't usually stop treatment on so soon after starting the treatment. Just 4 months. Well, was it 8? I think it's 4 months. They could potentially go on to placebo. So it's just an odd scenario. You've got a group of people who have by their nature have got sight-threatening disease, and you're proposing to put them into a trial where they come quick. Half of them are going to quickly come off the drug that you've just shown is working. And I think it's kind of like a fundamental thing about this trial, which we don't have. We're not comparing adalimumab with anything else. Yeah. So it's I've had quite a few patients just say thanks but no thanks. I want to go on the drug that we know works. I don't want to come off it within 4 months. Yeah. I sort of identify with that quite a lot.
Yeah, I mean, the only kind of the way we've tried to resolve that, I suppose, is by having the switching element. So if they do go on to placebo and they show signs of worsening disease, then they can be, they can repeat the treatment run-in and be switched so that they can be on adalimumab next time. But I do appreciate that that sort of then involves them having a worsening disease before that would happen, which...
And, often when you have a relapse, it chips away at your vision. So, yeah, I think it would have been nicer to have 2 arms in this. It's not, nothing to do now, but I think that's why we've had slower than expected uptake with this trial. A big group of patients I have who are on adalimumab, probably the biggest single group is birdshot, and they're such a sort of educated group of patients with, they're all in the chat rooms with each other. They know that adalimumab works, and I haven't got any of them to join the trial. Sort of relying on patients who don't really think it through.
Yeah, I mean, I guess
I wouldn't choose this for myself, for example.
Do you not have many other patients who wouldn't normally be able to get adalimumab outside of the trial that would then sort of be interested because it's better than nothing, or?
No, I've had a couple of patients who were thinking about it, and they hadn't yet had a first-line steroid-sparing agent, so they would have had access to it earlier than usual if they'd have said yes. But they took so long to make their decision that actually they became eligible whilst they were thinking about it. And the other person, we've got one person who's just being he's recruited and he's starting the treatment now, and he's got disease in one eye and nothing systemic, so he's not eligible for NHS adalimumab, but is eligible for the trial. So there's only one. There aren't that many people who have unilateral disease.
So you're
not tons of them.
So your patients are more people that would ordinarily be able to receive treatment
Yeah,
than those that wouldn't.
yeah.
Yeah.
I'm keep looking for these people, but I haven't got. They're not coming out the woodwork.
Yeah, no, that's interesting to know. Catherine, do you have anything of a similar vein to add?
Yeah, I think I'm exactly the same actually. If I've got patients who are already on a DMARD and a steroid and they've got active disease and I'm needing to go to the next step, then often they do want to say no because they want that guaranteed that they're getting on their treatment. They don't want to have that risk of 12 to 16 weeks later it being stopped. And I found that you do have to have a certain group of patients to do it, those who are willing to comply, willing to attend their set appointments and want to engage in research. So they're the ones I've actually found are happy to participate. It does worry me the fact that you say, oh yeah, but quickly we can get them straight back in. I thought that the more times you stop and start adalimumab increases your risk of antibody formation. So that always worries me slightly. And then the group that I am trying to get patients in, the beginner groups who are just on steroids, and they've got to be above 5. So the ones that I'm recruiting in there are my, new onset bird or new presenting bird shots who I'm seeing them, giving them high dose steroids. And normally I'd add then a DMARD in, I'd take the process a bit slower to then eventually go to adding in adalimumab. But for them, I'm adding it in at the first stage, and I feel that that run through is just too short a period to then get them to below 5 milligrams of steroid. And so I've had a couple that have entered, but we haven't been able to pass them through to the second stage because they haven't responded well enough. But you know full well that actually the drug's working for them. We just need longer time to demonstrate it and not get the steroids down as far. So I think that's I know you can't change a study, but I think that's for me is what's now sort of preventing me from adding those sort of patients in, is because I know I need to get them below the 5 milligrams by the 16 weeks. I feel I'm rushing their care. I feel
Yeah.
like I'm not providing the care for them that I would normally be.
Yeah, no, that makes sense. That's interesting to know. Yeah, I mean,
May,
as you
can I-
said, yeah.
Like, can I ask you a question? Because I haven't got so many patients through this trial, perhaps as Catherine, but I can imagine exactly the same experience. And often, what I would turn to with patients with birdshot or other treatments would be an Osidex. And I remember the Osidex was sort of off limits at the beginning of this trial. But has there been an amendment to the trial where we can use Osidex?
The only thing we're kind of
One-
changing
one-
that would permit it is when patients are having some kind of intraocular surgery. So for glaucoma or other things, we aren't changing anything to just permit it in the study generally, because that is an exclusion criteria, and so they shouldn't be being prescribed it throughout the study.
So I wouldn't regard it, if someone requires adalimumab plus intravitreal steroid implants, I wouldn't conclude that the adalimumab had failed. It's just often that people need both, and if you're then chopping and changing from placebo to real drug, yeah, this is, I don't think it's anyway. You can't change the trial.
No, that's useful though. I can discuss that with more clinical minded people. But yeah, I think the idea is because obviously the Osidex would improve their vision, that it would make it harder to determine if the adalimumab is having an effect.
Yeah, of course. Yeah.
Are we allowed to add it? So if we are going for those patients who are adding it in as a first line treatment and they then go through to the run through, the second stage, the randomized stage, we can't actually add in any other treatments at that stage, can we? Because then we're sort of classing them as not responding as well as you need them to have responded to enter them into that trial.
So generally the trial's pretty unprescriptive about other treatments. The only thing we say when they're in the randomized part is that the prednisolone needs to stay below 5. You can change their other medications as you see fit, or other immunomodulatory treatments. I do kind of see your point that if they've not had them to begin with and then you increase them, that would kind of suggest that the adalimumab's not working, but we aren't prescriptive about what other medications you use throughout the trial, so you can kind of chop and change other things if you want to.
Okay, but in a way, if they are in the second stage of it, and I'm needing to add in a DMARD, it's because their disease is too severe that wouldn't allow them to go into that stage, wouldn't it? So, so yeah, I need to have made that decision before they get randomised.
Yeah, and again, this is, I mean, I guess if you're saying it's not quite long enough, but that was the point of the treatment run-in, so you have some time to sort of change some of their other background treatments. But yeah, if you feel that the 16 weeks isn't actually long enough to necessarily do that for some patients, then obviously that is a hindrance that can't really be changed at this point. But yeah, I mean, you can change their other treatment as much as you like once they're in the trial. I will feed some of this back to Shri and Andrew as well, because it's useful feedback. And obviously I'm not a clinician, so they probably have some more useful things to say than I will, but that's good to know. Don't know if anyone else had any other comments or anything they wanted to share, any other concerns or issues? How's it going at South Tees, Ahmed? I feel like you've had quite a few patients enter the trial. We found it easy enough to recruit people or kind of convince people to take part in the study?
Yeah, it was easy from the point that the people I have managed to enroll didn't fit into the criteria for NHS to give them adalimumab, though that was easy to offer.
Yeah.
I've got already uveitis database in place, so it was easy to screen through them and identify who could benefit from that and enroll them.
And do you or like in regards to screening processes, do you carry out the pre-screening yourself of the patients in your clinics? Would you do it whilst they're in the clinic? Do you look at kind of lists before, or do you have anyone else that sort of does
Combination of both. No,
pre-screening?
I don't have anyone else who's got some kind of serious staffing issues actually, but yeah. I have like an Excel file on my desktop with the uveitis patients. So I go before the clinic, I go through the file and I may go through the notes before the clinics and then identify who can be approached. And then pre-screen them and then screen them.
And do you find that it takes much time to do the pre-screening? Is it an arduous process or is it quite brief?
No. It's part of my admin before the clinic, so it's not necessary to add much time, no.
That's interesting, thank you. And Catherine and Johnny, how does your sort of process work? Do you find it straightforward to pre-screen, or is it, are there any other barriers involved?
I mean,
go on, I'll let you.
Sorry, what? Oh, I was just gonna say I don't screen every single patient. I don't, frankly, have time. You know, I mean, my job is unmanageable as it is, but I don't, and by that I mean I don't fill out all the forms, but I'm always looking for people who could potentially join the trial, and if I think they might be eligible, then I'll fill out the form, but I don't fill out the form on every patient. Often, you know, we went through our database of uveitis patients at the very beginning of this trial, and we identified about 12 patients who were on at least on the information we had were potentials, and most of them just don't like needles. You know, they are eligible because they'd never tried a DMARD, and they'd never tried a DMARD because they were needle phobic, and then you sort of asking them if they wanted to do a trial without, you know, it was a non-starter. And then there was a few people who were just stuck on prednisolone, like 10 milligrams for years. It's not ideal, but they just are. They just wanted better the devil you know, is I suppose the phrase they would have been using, and it wasn't as massively high dose, and the uveitis from when I saw them wasn't particularly active. They were just like, actually, I don't fancy it. So it wasn't very fruitful going back through the old patients on our database. Really, I've just been relying on new cases arriving fresh each week and trying to get them in. And it's been quite random who's said yes and who said no. Yeah, it's normally the kind of quite sort of gung-ho, plucky people who are wanting to help medical science who say yes, rather than trying to predict it any other way.
Yeah. No, that's helpful. Thank you. Catherine, do you have any other things to add?
Yeah, I think I'm the same. I did try to at the beginning sort of pre-think through my list of patients who would be suitable based on if they were on just a small dose of steroid. But when I started having the conversations with them, I just felt I was sounding stupid because I'm about to start in the treatment that is the gold standard for when we introduce into patients with really bad disease, and I'm offering it to somebody who's on a small dose of steroid. And unsurprisingly, none of those accepted it. And then, yeah, as I am seeing a patient, if I feel that either a DMARD or the next stage of the drug is needed, I'll talk to them about it and ask them whether they want to be as part of a study or whether they want to just have it on the NHS.
Okay. So yeah, so I guess your point is either they're on too low steroids that it feels excessive, and then
Yeah.
the ones that are on high levels of steroids, they can just get it anyway. So it's
Yeah.
not worth
Or
the
I'm
trial.
worried about the speed of how to, it's the ones on high dose steroids that I'm worried about their disease
Yeah.
and theoretically then just being on one agent with the steroids that have to quickly come below 5. It just,
Yeah.
difficult.
That's interesting. Thank you. That's very useful information for me.
How long are we going to be recruiting for? Because I've got another lady who's a bird shot, that I'm thinking of trying to speed up her adding in her DMARD and then trying to introduce her into it, thinking if I can just slow down the process a little bit beforehand. But I want to take my time with her. So how long? And I sort of think she might be the sort of perfect candidate. A
Yeah.
retired police woman, bit of time on her hands.
Yeah, so assuming that the contract extension is approved, which we will get a response by the end of the month, we were told. I can't actually remember when it would be extended to, but another year or
Okay.
so quite a while. I think we would say try and end recruitment to the treatment run in next August, I think it was.
Okay.
So there would be a while on that.
Okay.
And yeah, so we should find out in the next couple of weeks, which we'll relay obviously to you as soon as we know. But hopefully, yeah, it would be quite a substantial extension to be able to recruit more patients into. Does anyone else have any insight? Michael will go through, or I guess Claire, you've already shared some things. Anything from your site that?
So Mr. Kumar, who's our PI, doesn't formally go through all of the notes to screen them, but is just aware, and when the patients come in, he speaks to them then. So we don't fill out the pre-screening form for every single patient, just the ones we think are suitable. So I think it's similar to what Jonathan was saying earlier.
Yeah.
And then, yeah, he'll call me to have a further discussion with the patient. And we've been selling it as, yeah, it's a quicker pathway to get access to the adalimumab for those patients. So that's how we've been approaching it. But I think we've recruited relatively few compared to other sites. Yeah.
And do you know if there are many patients that kind of fit your pre-screening criteria? Like, did you approach them all? Do you find that many of them want to take part, or do you?
So from the ones I've spoken to, we had a couple that have gone away to think about it, and they've spoken to other consultants from other disciplines because they've got other systemic things going on. But I think it's about 50-50, kind of interested in the study.
Yeah.
And in terms of the follow-up periods and attending appointments, the ones that are interested, the actual study schedule isn't really an issue. They're quite willing to come in and attend all the assessments, and even at short notice attend assessments and things.
That's good to know. Yeah, because there's quite a few appointments, and I think some of them can be quite long, can't they?
Yeah, so I think we've got. I think part of it is people with jobs that are quite flexible to allow them to have time off work to attend the appointments, because even the shorter appointments end up being sometimes half a day with all the imaging and other things that are required and bloods and delays and that kind of thing.
Yeah. But thank you. Gosia, do you have anything else to add?
Not really. I think I would agree with some of the people that already said the amount of patients we've got for uveitis. It's more than enough for our doctors, so they don't pre-screen everyone. But our PI is very sensible, and also the other doctor was recruiting, so they would definitely ask those patients who are would like to participate in the trial.
Okay. Yeah, I mean, I know the pre-screening kind of log processes can be quite admin heavy, so we do just say if you suspect that they would be eligible, then to carry it all out. You don't obviously have to complete it for those that you know aren't eligible, because that would be a bit of a waste of time. Just those that you suspect will be. Cool, that was useful feedback. Thank you. If none has anything else to add, I will move on to the next bit. And then, I just wanted to run through the consent form, because I've had a few issues with some of them, and I don't know if it's been very well explained. So this first statement, when it says, I confirm I've read and understood the patient information leaflet, that date and version should be the date of the PIL and the version of the PIL. So currently that's version 5, which is dated 28th of April 2022. So that will be the same date and version for everyone you consent. At the moment, I don't think we have any plans to update the PIL, so hopefully that should kind of be the date and version for the foreseeable. So just make sure when you're doing that, you're not doing the date that they were consented, or B, sometimes I've noticed people put in the date and the version of the consent form rather than the date and the version of the PIL. So just double check that when you're filling in this part. For all these sections, make sure the patients initial them rather than tick them. And then for the optional part on the bottom, please make sure that they do both, so they tick yes or no and also initial the box. And even if they don't want to take part in any of them, please get them to ask if they can, tick the no box and initial it, just for full completion. And obviously the date and signature of the patient and of the person taking consent. And when uploading this onto the A2 page on the database, just double check that you are uploading the consent form. I've had a few instances of people uploading the pre-screening CRF, which obviously is not what we're looking at. So yeah, just double check that you're uploading the correct consent form. So the screening assessments for consented patients, got the chest x-ray, the MRI and the ECG. The x-ray is obviously mandatory for all patients, but the other two are only if clinically required, so if MS is clinically indicated or if heart problems are indicated. In all cases, you can use a scan that's been taken in the last 6 months or the 6 months before the screening visit date, if they happen to have those, but if not, then you'll need to have one taken out. Have it repeated. And again, make sure that you have all the results from this back, and if you have any sort of queries around the results, make sure it's all resolved before confirming eligibility and enrolling in the trial. Again, with the bloods, so the infectious disease bloods, these should be taken either on the screening visit, or you can use them for the last 3 months if they already have them. And then female patients need to confirm that they're not pregnant. So an overview of the screening and baseline assessments, which you're probably quite aware of now, and they can generally, it varies how you do it locally, and you probably have a bit of a system now, but you can either do them within 1 or 2 visits. So obviously, if you combine the screening and the baseline visits together, you may end up collecting data for patients that don't pass the screening, but then just such is life. So it's kind of easier often. I think sites find to do it together, but it does kind of run the risk that a patient might be ineligible from the screening, and so then you don't need to collect the baseline data. But yeah, this is kind of up to local pathway, and I'm sure everyone already has a system for doing this. Once you've had all the results back, you have to complete the A5 CRF to confirm whether they're eligible or not based on the tests you've completed. Again, this bottom section has to be completed by a delegated clinician, so they have to be delegated to task 15 before, to confirm the eligibility before they can be enrolled in the trial. Once you have confirmed eligibility, you should enroll them within 24 hours of this. So there's a checklist of tasks to complete, which is on the A6 form, but generally you need to enter the minimum data set, which is the A1 to A6 and also the B1, and once you've done that you can generate the prescription. So this is downloaded from the database, and that's the P1. And then if you get the patient registration form as well, which you can get from the master file, or you may have it on file already. So once you've completed the prescription and the registration form, they need to be signed by the clinician and a pharmacist, and then emailed over to Sciences. And if you make sure you email them both together, and just double check that you've completed them in full, because there are any sort of queries on the prescription or the reg form, it can cause a delay in patient treatment. And we also ask that you, if you don't have any other kind of contact, make sure to contact the patients about 2 weeks after emailing the prescription, just to confirm that they have had contact with Sciences. Unless you've heard otherwise already. Claire, did you want to add? I don't know if you're talking, but if you are, you're on mute.
The purchase order.
Yep.
This is opened a huge bag of kind of worms here. It has to go. It's with it not being dealt with here locally. It's caused a lot of confusion in pharmacy here. So it has to go to a different team altogether to obtain the purchase order. Nobody really wants to sign it, pharmacist wise here. And so does it really need to be seen by the pharmacist?
So you don't necessarily, I've had confirmation, you don't necessarily need to countersign by a pharmacist, but you do need the PO number, because that's how scientists kind of carry out the invoicing of the drug. So that kind of needs to be done. I think if there's not a PO number, they will still process the prescription and deliver the drugs, but then they'll just end up hassling for PO numbers later down the line and to try and sort out the invoicing.
Right.
So that is a kind of required part of it.
Because it's a totally different route to get that purchase order.
Yeah, do you have like a home care pharmacy department?
Yes. Yeah, so it specifically needs to go there rather than general, because it's caused an awful lot of confusion. It's been an absolute nightmare and it's still not resolved.
So I think normally sites that have home care pharmacy teams, it would go through the home care pharmacy because they have to generate the PO number. I don't know if anyone else has any useful advice for Claire about that, if you've done it successfully at your sites.
Because they said it still needs to go through the normal route, because it's really convoluted, and I don't know if that's completely wrong anyway. That's just what somebody said, but it's completely taken out of my hands, and it's not been resolved. It's just been an absolute nightmare.
So who have you passed it on to? Like, well,
it's gone to home care, but
okay.
Someone else seniors took over and said it still needs to go through the normal pharmacy route, but it shouldn't, because it's nothing to do with pharmacy.
Oh, so they want to go through your general.
So they want to go through it, and it's just, so it's just about going through home care and getting a purchase order.
Yeah, so you can just go through the home care pharmacy team, and you wouldn't have to go through a normal pharmacy team. I mean, it's difficult because different hospitals have different processes that put up different things, but generally speaking, from what I'm aware of, people go through their home care pharmacy alone, and that should do it.
Obviously not, but that's just here. But that's fine. All right, thank you.
No worries. So yeah, once a patient has been enrolled, we provide them with the patient pack, which obviously we provide to you, so do let us know if you need any more. But this contains information on the injections and the patient card, the travel card, and the injection diary, as well as some alcohol wipes and do not use labels. If you need any more things like alcohol wipes separately, then just let us know and we can send them over. So as you're aware, once you've enrolled a patient and you send the prescription and the reg form to Sciences, they will arrange the drug delivery, and this is followed up by a nurse visit who will train the patient in how to use the device and also kind of administer their induction dose with them. After this visit, so within about 24 hours of the visit, they should be sending you a clinical evaluation form, and this has the date of the visit, any injection competency, if they're happy that they know how to take it. If they need to have a second visit, it will outline it on there, and they'll also outline any adverse events. And this will get sent to the hospital. So Sciences, obviously previously Healthcare at Home, they provide this sort of delivery and training throughout the UK. And they, as I said, they deliver the study drug to the patient's house, and then the registered nurse will provide training in the participant home. They send the clinical evaluation form, which has information for the D1, so make sure you do receive that because that's required to enter onto the D1. And the date of induction dose, which is taken from this form, is what informs the 4-week follow-up visit. So it's important that you kind of get that as soon as possible after the visit. If you don't receive this KEF within 48 hours of the known induction dose, then do contact Sciences, or if you can't get through to them for any reason, you can let us know, but do make sure to kind of chase that up if you are aware that you've not had it. I was going to ask if you know of anyone else at your site that might need to be added to this list. I think generally speaking, everyone is getting the forms, but if you do know of anyone who has not received them and you want them to, or if there are any change in staff, then probably easier to drop me an email with the email addresses on rather than let me know now. But yeah, do get in touch about that. And on the topic of Sciences, I wanted to discuss their new kind of portal system that they've introduced. So this is something that they use generally for all patients that are on their service, and it allows you to log on and see relevant patients' kind of Sciences account, and you can view their records, see information about their medication, their prescriptions, any sort of conversations they've had with Sciences, or any historic and planned activities such as the nurse visits. It allows you to track the patient's prescriptions, and also put any patients on hold if you need to pause their treatment for any reason. And the idea is you can access a lot of information about the patient's prescriptions and nurse visits, and it is more information than we have access to. I have spoken to a few sites who have managed to get access, and they are using it successfully and have said it's been useful because they can, see an overview of what's going on. I don't know if anyone here has managed to access it, or if you've tried and failed, or if anyone has any feedback at all about the Sciences portal, it would be useful. No?
Can we just sign up for it if we just go on the website on the how do we gain access?
I probably should have said that, shouldn't I? So you can either gain access through your home care pharmacy team. They can kind of help you set up with an account, or if not, then I can pass on an email address of my contact who can help set up an account. It's probably easier actually if I do that. So I can send you his email address and you can contact him to set up an account, and he'll go through some kind of overview of information.
Okay.
Otherwise, yeah, you can talk to your pharmacy, but I know some people have had issues with doing it through their own pharmacy, so I can just relay my contact details. Presumably no one else has used it based on the silent response. Okay, I'll send out Chris's email so that hopefully you should be able to set up an account and get access to that.
Please do.
Perfect. So once patient's been enrolled and they're in the treatment run-in, their TRI follow-up visit and their injections are all scheduled from the date of the induction dose. So the injections are fortnightly, starting from 1 week after the induction dose, and then you've got the 4-week, 8-week, and 16-week follow-up visit. At this 16 weeks, they're assessed to see if they're a responder, and they're randomized to drug or placebo. If they're not a responder, then obviously they exit the trial. These are just an overview of the assessments carried out at each visit, and also obviously they're in the protocol. And at the week 16 visit is when you carry out most of the assessments to determine if they are a responder or not. And just a reminder that both the OCT and the colour fundus are required at all of these imaging visits, so at baseline, week 16, and at the RCT visits. But the autofluorescence and the FFA is kind of only required if clinically indicated and if used for those patients. So the responder criteria is outlined here and on the CRFs. So they need to have no active inflammatory chorioretinal lesions, a CMT of less than 320 microns, no leakage indicating active retinal vasculitis, less than or equal to 0.5 vitreous haze, and being on 5 milligrams or less of prednisolone whilst kind of maintaining the disease remission. So if they meet all these criteria, they can, they're classed as a responder and they can be randomized to drug or placebo. This is just kind of a reminder of completing the V3G CRF. So this is the responder assessment CRF. There's a section at the bottom which you complete for responders only. So the top bit, so this form is the CRF and the bottom one is the database. And the top bit in blue is what you complete after the first treatment run-in. So if they're a responder and they've provided verbal confirmation they're willing to start the randomized trial, this bit you tick yes to, and that's when you go on and randomize them on the database. If they have gone through the second or third treatment run-in, then you'd answer the question below, which is highlighted in green. So that's just if they've provided verbal confirmation they're willing to continue with the randomized trial and sort of swap arms on the RCT. And it's important that you fill in the right question at the right point, because if you answer yes to the second one, it causes like a switch on the IMP database, which switches the patient's allocation. So only complete that if that's required, but at the end of the second or third TRI, try not to accidentally complete that after the first TRI. So for the responders, you will enter the minimum data set onto the database. So that's the V3A to V3G form, as I've just shown. And you need to have a clinician sign off that they're eligible to be randomized. And then you randomize them using the ECRF. The P2 prescription is downloaded at that point and emailed over to Sciences once you've had the clinician and pharmacy sign off. You don't need to send a registration form as well. You just send the P2 prescription over. When a patient is randomized, all the kind of follow-up visits and injection schedules are based on the date of randomization. So the injection should start 1 week after randomization and fortnightly from there. And then they have the follow-up visits every 12 weeks up until 48 weeks and then 16 weekly after that. At each of these visits, treatment failure is assessed. And if you feel like your patient has kind of had deteriorating vision and treatment failure is suspected outside of a scheduled visit window, you can bring them in for an unscheduled visit to assess this failure, but you would need to complete kind of all the RCT CRFs, so the V4A to V4G. And if they have treatment failure, they can repeat the TRI at that point, but if not, then they'll still need to sort of attend their next scheduled follow-up visit. So these are the assessments at the RCT visits, and this is like what they had completed at the end of the 16 weeks. And the follow-up ends once all patients have had a minimum of 48 weeks in the trial. So the treatment failure criteria, again, this is on the V4G CRF, but it's if any of these are reached. So if the patient is on more than 5 milligrams of prednisolone, if they've got new active chorioretinal lesions, if they have an onset or worsening of retinal vasculitis, they've got a more than 15-letter decrease in the BCVA, sorry, a 15-letter or more decrease, an over 20% increase in central macular thickness, and then a 2-step increase in the vitreous haze bioscore. And all of these are sort of in relation to the 16-week TRI visit response, so not in relation to kind of the baseline or any other visits. It's all based on the 16-week visit. If a patient does have treatment failure and they choose to repeat the treatment run-in, the repeat treatment run-in is scheduled immediately from the time where the treatment failure is identified. So a P3 prescription needs to be emailed to scientists as soon as possible. This allows them to sort of have the open label drug again. So we ask that you do it within 24 hours to minimize any delays with prescriptions. We also recommend that you contact the patients about a week after the prescription has been emailed, just to check that scientists have made contact with them. I do also follow these up with scientists on a weekly basis, so hopefully they should all be picked up and processed quite promptly. The patients continue with their existing fortnightly schedule. So where their last injection was in the RCT, their next, first repeat treatment run-in injection will be 2 weeks after that. And so the follow-up visits therefore are sort of scheduled from when the RCT visit was due, which isn't necessarily the same as the date it occurred. I'll go over this in a little bit more detail in a minute. But yes, scheduled from the date that the visit was due, or if it happens an unscheduled visit, then it's the date of the last injection plus 7 days. And we also have the injection schedule, which I will show you, that kind of outlines when the injections are due and when the follow-up visits are due. This is the V4G CRF that has a treatment failure criteria. And again, it's important that this part at the bottom that I'm highlighting is completed correctly. So you only need to fill in this section if the patient has had treatment failure. If they have not had treatment failure, then just leave it blank, send off the P2 prescription and just carry on with the RCT. But if they have had treatment failure, then you complete this section. If the patient is happy to repeat the treatment run-in, then you mark this as yes. And so this is the CRF, and on the bottom is the database. Once that has been entered as yes and saved on the database, it causes the IMP switch. So this is what tells the database that the patient is moving back onto the open label adalimumab rather than the blinded drug. So do make sure you complete this correctly. If you mark that as a yes by accident, it will still cause a switch. So just let us know if that happens so that we can sort of unswitch it. If the patient has had treatment failure but doesn't want to restart the TRI, then obviously that's fine. But then mark this as no, and that counts as a withdrawal. So then you have to complete the W1 form as well. So I just kind of mentioned all this a minute ago, but if a patient has treatment failure, you indicate this on the V4G CRF, email the P3 prescription to scientists, and then they complete the TRI as per the first time. So they have the 4-week, 8-week, and the 16-week visit. And it's the same CRF you used before, so the V1, V2, and V3. If they're a responder at the end of the repeat TRI, then you will enter the information on the database just by completing the V3G CRF and indicating that the patient is willing to continue in the RCT. That again causes the database switch, so you wouldn't need to re-randomize them. Just by entering that V3G CRF is sufficient. And then this restarts the RCT follow-up schedule. And so the next visit is at 12 weeks and then 24, 36, 48, as per the RCT the first time round. And any non-responders at this point just exit the study. We have a whole bunch of working instructions, which I have actually indicated above, which kind of outline what to do in different parts of the study. And we've also got the injection schedule to calculate the visit dates. So just an overview: in the treatment run-in, everything is scheduled from the date of the induction dose, but once randomized, everything is scheduled from the date of randomization. So this is a spreadsheet I've made to kind of try and help work out when doses are due and when visits are due. So this is the first treatment run-in. If you put in the date of the induction dose in the yellow box, it will populate when all the doses are due and also when the visits are. And in the TRI, these are sort of +7 day window. Once a patient has been classed as a responder and is randomized, then you use the second part of this spreadsheet and put in the date of randomization in this yellow field, and that will populate the injection dates for randomization and also the clinic visits. What kind of gets a bit more complicated is when they have the repeat treatment run-in, when they've had treatment failure. So this is on the second sheet of, I've recirculated, I have sent out previously, but I'll recirculate the spreadsheet. And this is on the sort of second tab along the bottom. If they have treatment failure, then in this yellow box you put in the date that the RCT visit was due. So if it happened at their 12-week visit, you put in the date that that 12-week visit was due. If it occurs during an unscheduled visit, then you use the last injection date plus 7 days, and that kind of sets the baseline for the repeat treatment run-in. And then this will populate and tell you when the doses are due and when the visits are due. And then again, once they get to the bottom here and they're a responder at the second or third repeat treatment run-in, the part on the right will just auto-populate when all the RCT doses are due and also the clinic visits. So there's nothing you need to enter there. It will just kind of go across based on what has been entered previously. It's a bit convoluted. It should in theory help. If you have the spreadsheet in front of you and play around with it, it makes a bit more sense. Give me a shout if you get stuck with how to use it, and I can run through and check that any dates align with what I would expect. So just an overview of the prescriptions, you've got the P1, which is the enrolment to the TRI at the very beginning. P2 is in the RCT. P3 is when you have treatment failure and then they're enrolled to do the repeat, well, re-entered into the repeat treatment run-in. And then P4 is a single replacement pen prescription. So the P4 isn't downloaded on the database, it's a separate CRF, and that can be used if, for example, the patient's pen doesn't work for some reason and they can't use it, or if it's been left out the fridge and therefore that's unusable. You can use a single replacement pen to sort of order additional extra pens with Sciences. For the most part, for the P1 and P3, you don't really need to do anything on the prescription, it's just as it is. But on the P2, you need to make sure you tick in this box which visit interval they're at, how long in the study, how far through the study they are. So it's important that for the very first RCT prescription, you tick the first box. And then after that, it's either 12 weekly or 16 weekly, depending on when their follow-up visits are. This is required to be signed by the prescriber. And this is where we've said it needs to be signed by the pharmacist on the bottom, and add the PO number somewhere up here. The name of the prescriber and the pharmacist needs to be entered onto the database, onto the P form. We don't have a CRF for that, but it's kind of taken from this prescription and entered onto the database. And it's important that the prescriber is on. It's important that the prescriber is on the delegation log to task 21. And this is something that we monitor on the database. So we do ask that you enter this information quite promptly onto the database. ImTrack, I hope most people have been using it. So this is what we use to kind of keep track of the pen allocation to the patients. It's mostly used by Sciences, who use it as a database to pick the packs that they send to the patients. But we do ask that the patients return their empty packaging to site so that you can log this onto ImTrack as sort of a proxy for acknowledging that the patient has used the pens. I appreciate that often that's not possible, or they might throw away their packaging, or they forget, or for varying reasons they can't bring it in, and that's fine. But we do just ask that you try to sort of remind them to bring it in and to monitor this on ImTrack. So yeah, there's not so much you have to do on here. There's a few different buttons, but really all you need to do is log the return and destruction of the IMP packs. So the questionnaires that hopefully you've been given to the patients at the baseline, so at the start of the treatment run-in, the 16-week visit in the treatment run-in, and then all RCT follow-up visits. We provide the questionnaire booklets, but also you can download it from the master site file if you want to print them locally. The biobank samples, so these are the optional research bloods. They're taken, hold on, over here. So yeah, both of them, the whole blood and the clotted blood, so the serum and the DNA are both taken at baseline, but then it's just the red top serum that is taken at the future visit. So that's at the TRI week 16, RCT week 48, and then any RCT visit where treatment failure occurs. So yeah, the purple one only needs to be sent at baseline, but it's the red one that needs to be sent at more time points outside of that. You don't need to do anything with them. You just put them in the safe boxes that we provide and send them to the biobank team in Oxford. Please make sure you write the study ID on the tube and the date that it's been taken, and then if you email these two people below and let them know that you sent the samples, If you take the samples on a Friday, then just keep them in the fridge and post them on Monday, but otherwise you can just post it the day that it's been collected. We provide these safe boxes. They used to be like big plastic blue things, but now they're cardboard boxes, so just bear that in mind. The retinal images, all images you take need to be sent to CARF, and hopefully you should all have been able to do this. I think often the photographers will do it, but this is the OCT, the colour fundus, autofluorescence, and the FFA. And when these are taken at the baseline, week 16, and the RCT visits, it needs to be sent to CARF for storage. And just, brief overview of the visual acuity assessment. So the optometrists and the photographers don't need to be certified and also don't need to be on the delegation log or have carried out study training, as long as they are completing the roles that they would do ordinarily. If they do have GCP and CV, then it's useful if they do sign up for delegation log, but if they don't, then that's fine. The BCVA should be taken at every visit, but refraction only needs to be done if there's a 10-letter drop in BCVA compared to the best score in the trial. The safety reporting, so adverse events, you need to collect them through regular sources, medical notes, patient reported. Sciences AEs would be reported at the nurse visit, and also anything from the GP. Make sure these are all documented on the CRFs. So kind of the A CRF of each visit is sort of the overview of how many AEs have been reported. And then we've got the AE1 form, which records the detail of all the adverse events. Where possible, can you please use the AE2 events coded list? So there should be a code based on what kind of the AE is, and where possible, if you can categorize it. But if not, then just put it down as other and sort of explain what the event was. If it's been serious, if it's a serious event, then you need to report it to BTC within 24 hours, and then we'll report it on sort of as required. Big overview of the CRFs. I won't really go through these, but we do also have some working instructions that show the overview. But generally speaking, the A and the B and the C are sort of the screening baseline visits, so baseline details. The D1 has the first dose information, and then all the follow-up visits are the V3 forms. So V1 is 4-week, V2 8-week, V3 16-week, and then V4 is the RCT follow-up forms, and they're repeated throughout all of the RCTs. So you just use the same forms for the 12-week and the 14-week, 24-week, etc. The database has the randomization form, and we've also got the R1, which is like a randomization checklist, and then the M1A and the M1B are medication forms. These are some additional forms that you may or may not need throughout the study. And again, there's sort of an overview of them on the working instructions. So the online management system, everyone here will have been registered to it, but as you know, this kind of contains the delegation log and the site file. Just a reminder that when people register for the delegation log, they need to select appropriate tasks. We ask that all clinicians are delegated to 15 and 21. So this is signing the eligibility and prescribing the intervention. And then make sure you upload a signed CV in GCP, which is within the last 3 years. And when new staff register for the delegation log, they need to complete a training log. And this needs to be done before we can approve their account. And they also can't access their account until it's been approved by us and by the PI. So on the homepage, you can see where you fill in the training log. And if you can just make sure any new staff both sign up for the delegation log and complete this training log in full, and then we can approve them. And this needs to be approved before they start working on the study. If you want to view the delegation log for your site, you can do this on the database as well. So you should be able to log in and just click the delegation log button, and they have a list of patients below. Anyone in green has been approved, but anyone in orange is awaiting a PI approval. The investigator site file is also held on here. So the local site file has your localized documents, and then the master site file has more generic documents. This is where things like the study manual and everything is kept as well. So it's worth sort of familiarizing yourself with what's on there, because often there will be lots of guidance and useful information that you can access. And then the trial database is accessed through here, but this can only be done on an NHS computer. When entering data, please do try and resolve all the data queries as you go along. This is something that we monitor and also is required for us to send activity reports. So if you see the little purple exclamation mark, that means there's a query with the data. So please try and keep on top of them as you enter data. There will be some that are sort of issues with the database, which I'm trying to fix before I leave, and hopefully it will reduce the amount of queries, but just pay attention to what they are. If it's queried things like blood test results, just make sure what you've entered is correct, and if it is, then you can just exclude it and say that that's the right value, and we can take a look at your reasons for excluding these things. So yeah, brief trial updates, and we're submitting an amendment hopefully next week, which will, having said all of what I've just said, change the repeat treatment run-in schedule. So we're going to amend it so that if a patient has treatment failure, it kind of resets the schedule so that all the injections and follow-up visits start 1 week after treatment failure, rather than basing it on the date that the visit should have been due. We're sort of changing it so it's just the date that it did happen. Hopefully this will make it easier to manage in future. We're also permitting patient training to be carried out by site staff in exceptional circumstances where it's been sort of pre-approved by us and also your PI. We're clarifying intraocular surgery during the RCT and also adding some details on unscheduled visits. I'll send obviously more information about this when we submit the amendment and provide an update on that. Trial extension, as I kind of touched on, we submitted the extension request on the 6th of September, and they said they'd turn it around hopefully within a few weeks, so we should know by the end of the month. And yeah, the plan was to, it's a 27-month extension in total, of which kind of the last 7 months is analysis by the BTC and the last year is follow-up. So I guess that's about another year of trial recruitment. And then finally, the staff change, as I mentioned earlier. So I will no longer be working on the ASTUTE trial after the 28th of September. Someone else will be taking over, but Rachel will be covering in the meantime. And then Sophie will also be working as a trial administrator. So yeah, I mean, we've gone through quite a few things anyway, but I did just want to ask 3 below questions. If anyone had any additional information they wanted to share, that what has worked well or what has been unexpectedly challenging. We've kind of gone through that in terms of recruiting patients, but once patients have been recruited, have you found there to be any issues that you weren't expecting or things that have been more difficult than you thought? And then finally with that, is there anything that you think we can do to help with that, or any processes that could be clarified or simplified? Don't know if anyone has any comments, things to add. No. Michael, I'm going to ask you first then, since you're first in my list. Do you have anything that you, yeah, I mean, I guess we've gone through recruitment, but anything particular once patients have been recruited that you think has been difficult or easy?
So I've probably pestered you quite a lot with different questions. We had a patient that had a unscheduled visit after our randomization and was a treatment failure. So none of our patients had reached the RCT stage by that point, so I wasn't really aware of what to do next. So I think the guidance you sent through about the treatment, what to do on treatment failure visits or unscheduled visits, sorry, were quite helpful, as I think we probably didn't cover all the bases in terms of, it was more of a clinic focused visit rather than considering all the information you guys would need on the trial side.
Yeah.
So I think when I had to complete those forms, a lot of it was information we didn't have because we were just focused on, oh, they had a massive flare up, we need to get them under control. So we probably didn't do all the imaging and all the other bits that are required for you.
Yeah, that's something that we've actually added onto the kind of protocol amendment, is to kind of clarify that if patients do come in for unscheduled visits, that they do need to have the tests carried out in full, or as as much in full as possible.
Yeah, because we definitely didn't do that on that visit.
No, okay, that's fine. I mean, yeah, I don't think that's particularly clear, and I think it was something that wasn't really thought about at the beginning of the study, that patients would come in for these unscheduled visits. So once until it happens. Yeah,
because we didn't really anticipate it either, because she was fine on the first follow-up after the RC randomization, and it was just in between that first one and the second one. Yeah, we thought the kind of washout period, if they're on placebo, would have hit by that first post RCT. Yeah.
Okay.
But,
No,
yeah.
yeah. So yeah, we are clarifying that in the protocol, and I'll probably put some more guidance out about that as well, because it's becoming more common.
Sorry, just a question. So earlier you said, so when this, so we've re-put the patient through the trial run-in. So when it comes to when, say, they're a treatment success at week 16 again,
Hmm.
I don't need to re-randomize them. It will automatically go through to the
Yeah.
other arm of the trial.
If you just complete the V3G CRF, so I think I highlighted earlier, it's like the second
Yeah.
question says, is the patient happy to continue with the trial? I
Yeah.
think it says. Yeah, as long as you complete that bit and enter it onto the database, then it just does the switchy thing, so you don't have to
Okay.
re-randomize or do anything else. There's no other
Okay.
forms. It's just entering that information.
Yeah. Okay. Yeah, I think that's it.
Cool. Does anyone else have any comments? Have anyone, I don't know if I dare ask, but how anyone's experience with sciences have been recently? If there's been anything particularly bad or if things have been going smoothly. I feel like I've heard a bit less, but that doesn't necessarily mean anything. Has anyone got any feedback on that?
I mean, the most recent patient we've recruited, I can't really work out whether it's his fault or science's fault, but it's taken so long to get him on the injections. I mean, he's starting this weekend, but we referred it ages ago. It's slower than the local. Well, I don't know if it's local, but the company who we use for our adalimumabs on the NHS tends to be quicker.
Yeah. Do you do that with a kind of the similar sort of system? Is it a third-party home care
very
thing?
similar.
Yeah. Who do you use in your
I think
usual care?
we used to use the Ensys. I don't know why we've stopped, but we moved to a different one. I think it's just because we changed the brand of our adalimumab that we were using in the trust.
Right,
but,
yeah.
I don't know why we changed.
It has been slightly slower, I think, than what was expected at the outset. I know there, in quite a few instances, there have been random issues with prescriptions that slow things down. And yeah, unfortunately, it has been slightly slower than we would have liked. But hopefully, once they're sort of in the trial, there should be less issues with it and like no delays. It's just can sometimes take a bit longer to begin with.
Can I just add to the prescriptions issues? We would have hoped that that would be communicated to us if there's something's wrong, so we could just immediately react and correct the prescription instead of them going through you or.
They do have contacts who they are supposed to, if they have an issue, the DUI team is supposed to get in contact with someone on site. So I can check who they have listed for that. Quite often, for quite a few people, it's been like pharmacy teams rather than the research team, which I think can be where things get held up because they might go back to pharmacy and say this isn't right, but then that doesn't necessarily get relayed to you.
Exactly.
So I can double check with them who is on their kind of contact list and make sure that's updated.
Okay.
And that's the other kind of, if you can get access to the Sciences portal, you should be able to see on there if there have been any issues with prescriptions too. So that should highlight it as well. Sort of remove the middleman. But yeah, I'll double check who's on your distribution list.
Thanks.
Anyone else? Catherine, do you have any comments on the Sciences or anything else at all?
I think we had trouble recently, but yeah, I think you're never going to get over the top of their problems. I think they aren't a brilliant company. They've got, the staff isn't brilliant. I think one patient waited in for the prescription for the meds, and they said that they tried and they hadn't, and they obviously hadn't tried because a psychiatrist is not going to lie about that situation. So, yeah, I don't think it's not your fault. It's unfortunately you've got a company that's not very good.
Yeah, I'm not really sure why they were picked at the beginning, and I think at this point it obviously would be too difficult to try and change.
Yeah.
So we just try, put some processes in place to reduce the possibilities for issues, but I guess they're never going to completely dissipate.
Yeah, I mean, it did create a wobble recently with somebody who, when the delay came in, I said, it's up to you. We come out of the study or we don't. So,
yeah,
if patients involved in the study, they're normally quite keen to stay in. So, yeah.
Okay, thank you.
Apart from that, it's okay.
fab. I don't think I had anything else I was going to run through. I'm going to stop sharing my screen. So yeah, before I draw the session to a close, just quite perfect timing. Don't know if there's anything else anyone wanted to raise whilst we're here, or ask anyone else about that might have more insight than I do into recruiting and managing patients in the study. And obviously, if you ever do, then just drop me an email. No? Okay, cool, perfect. Thanks everyone for coming along. It's been very useful for me. Hopefully it's been useful for you as well. And yeah, as ever, give me a shout if you need anything. But yeah, I'll stop sharing.
Thank you. Thanks
Thanks,
for your help over the last year.
Thank you.
Thank you.
No worries.
Thank you.